Is it visible?
Yes, ma'am, it's visible.
Okay. Okay. Today we are dealing with the topic nausea and
Slide
vomiting.
mode.
Am I audible?
Ma'am,
Slide
can you
mode.
please put it in the slide mode?
Yeah. Yes, yes. Okay.
Yes, ma'am.
Okay. So today we are mainly discussing the topic nausea and vomiting. So let me start. Usually there are common GI symptoms we are come across in our palliative care are oral thrush, stomatitis, dry mouth, nausea and vomiting, constipation, diarrhea, and intestinal obstruction. So here we are more discussing about nausea and vomiting. Why we are more discussing about nausea and vomiting means the 40 to 70 percentage of the patients with advanced cancer has nausea and vomiting. So we are more commonly dealing with our palliative care patients. In our palliative care, both the cancer patients and non-cancer patients are seen. So in among the advanced cancer patients, 40 to 70 of the patients has the symptoms of nausea and vomiting. So that is why we are studying, or we are more knowledge. We get more knowledge about nausea and vomiting and its management. So the management involves the accurate assessment, because usually if someone coming with nausea or vomiting, usually we are prescribing emisate. This is our wanted drug. This is usually we are giving emisate for all types of vomiting. But after this class, you have to think before giving emisate, because you have to identify what is the cause of the vomiting for each patient, and you have to manage according to the cause. That is why we are dealing this topic in detail as a session. So you have to know what are the various mechanism of triggering vomiting. That is, what are the causes. In our coming slides, we are more in detail about each mechanism and what are the other causes. So there is a targeted drug therapy. That is, it is a cause-based treatment. That is what you have to find out the cause and give the medicines appropriate for the cause. That is our main goal. And rather than prescribing same antiemetic, you have to find out the cause and give the appropriate antiemetic for each vomiting. So how will it affect? That is why the nausea and vomiting will affect a person. Usually, it will affect the patient's daily function. That is very, very important, because if somebody is coming with vomiting, because of the severity of vomiting, it will affect the daily activities. Maybe you're not able to take food, not able to take bath, not able to walk, not able to attend a function. So it will mainly affect the patient's daily functioning, and it also hinders the quality of life. Usually, in our palliative care, we are more focusing on the quality of care for each person or patient and their family members. So, if because of these symptoms, it will affect the quality of life of a patient. The next thing is non-compliance to treatment, because if the most of the time the cancer patients or the pain patients, while we are giving analgesics, or the patient on chemotherapy, because of this vomiting, nausea and vomiting, most of the times the patients are not willing to proceed with the treatment. So there is a non-compliance to the treatment for each persons. So that time also you have to think that you have to give an appropriate medicine for appropriate vomitings. Next thing is inadequate symptom control. Because of this inadequate symptom control, the most of the patient has a fear of anxiety or poor absorption of medicine. That is, most of the time the patient is taking medicines, most of the medicines are vomited out. So there is a poor absorption of medicine. Then and the patient has a feeling of anxiety because of the continuous vomiting, and the oral intake and the fluid intake will be reduced due to the fear of vomiting. And apart from these symptoms, there is a distress factor. That is not only for the patient, this more also for the family also. So if someone more beloved to us is have these symptoms, this continuous vomiting and not able to take food and not able to do anything. So it will more causing more distress to the family members also. So in our palliative care, we are focusing to the patient along with their family members. So that is also very important why we are more studying the nausea and vomiting or other GA symptoms. So usually what is emesis? Emesis means vomiting. So while we are dealing with the definition, it is a biological defense mechanism to remove the toxic or harmful substances from the body after injection. So it is a biological defense mechanism. If some toxic material or some harmful substance which enter into our body, so it will remove out with a biological defense mechanism, that is emesis. So before this emesis, or for this process of emesis, there is some phases. So these phases include, it is a nausea, it's a process of retching, this process of that term vomiting, and sometimes it is a regurgitation. So in the coming stage, we are dealing what is nausea, what is retching, what is vomiting, what is regurgitation, what are the differences between these four terms. So what that is nausea. The nausea means it is an unpleasant sensation of the imminent need to vomit. That it is not an vomiting. There is no expulsion of the things. There is, the patient has a sensation. It's an unpleasant sensation, and the patient is imminent need to vomit. There is just prior to the vomiting, there is a unpleasant sensation. There is no expulsion of contents in this nausea. So next, the term is retching. It is a spasmodic respiratory movements against a closed glottis with the contractions of the abdominal musculature without expulsion of any gastric content. Here we are more focusing that there is a closed glottis. The movement is the spasmodic respiratory movements, and there is without expulsion of any gastric contents. Here also the gastric respiratory movements is there, abdominal muscle contractures is there, but the expulsion of the gastric contents is not happen in the retching. So there is mild difference between this retching and vomiting. Here, there is a forceful expulsion of gastric contents through the mouth associated with this contracture of the abdominal and chest wall musculature. Here, the content is expelled out. In the regurgitation, there is no expulsion, but there is a contraction of the abdominal muscles and there is a closed glottis. Here, vomiting, the forceful expulsion is happening. That is the difference between regurgitation and vomiting. That not regurgitation is a retching and vomiting. So next is regurgitation. It is brought back to mouth without the contraction of muscle. Here, the something in the gastric contents will come in the back of the mouth, and but without the contraction of muscles. Usually, this regurgitation is seen in the GRDs. That is, there is some loosening of this valve in between the esophagus and the stomach. There is some gastric contents may brought back to the mouth without any contraction of this abdominal or chest wall muscles. So these are the difference between the four terms. If you have any doubts, you can ask in between. Okay. So next we are dealing what are the different types of vomiting. So while we are discussing the type of vomiting, that is depending upon the time, or that is the when they occur. That is, it may be an acute, it may be a delayed, it may be a breakthrough, and it is a refractory, or it is an anticipatory. So when it is an acute vomiting, it is occurring within a few minutes of maybe chemotherapy, or few minutes of injection of any toxic substances, 2 hours, and it will be resolving within 24 hours. This is an acute thing. That is, it can occur within few minutes to hours, and it will be resolving within 24 hours. Then it is known as acute. When it is known as delayed, if it is occurring usually after 24 hours of chemo, and it will be worst from 48 to 72 hours following chemo, and it can last 6 to 7 days. This is the delayed vomiting. That usually occurs after 24 hours, but it can be last for 48 to 72 hours, and maybe it may be for prolonged to 6 to 7 days. So this is the delayed vomiting. Next thing is breakthrough. Breakthrough means it is occurring despite the patient is an antiemetic treatment. That means the patient is maybe the patient is on emisate or some metoclopramide, that is as a tedious dose, but in between there is a breakthrough episodes of vomiting. That is breakthrough. Next is a refractory. Refractory means it is an unmanageable with current antiemetic. So we will try most of the antiemetic drugs, but there is this not controlling with any antiemetics. That is unmanageable with our current regimen. Next thing is anticipatory. Anyone tell what is anticipatory vomiting? Anyone heard about anticipatory vomiting?
Before any treatment or before taking any food or prior to the treatment or any procedure.
Yes, yes. Sister Rini, you are correct. That is, usually it is a conditioned response prior to chemotherapy, because sometimes the patient has a chemotherapy on every Saturdays or every Fridays of weekly Fridays. So just prior to that day, the patient has a fear or anxiety about that chemotherapy and also the series going through after the chemotherapy. So because of the fear or anxiety part, the patient has an episodes of vomiting just prior to that day. That is a cycle. So if the some caregivers or family members will come and tell that the patient has similar type of vomiting, this is you have to think that it is an anticipatory vomiting. So the drug of choice or the management is entirely different from the normal antiemetic. So that you have to identify what is the anticipatory vomiting. So next, what are the causes of vomiting? Causes means what are the things which can cause vomiting? That is, first thing is chemically induced nausea. That is usually drugs. Commonly, we are using that opioids, antibiotics, cytotoxic drugs, and some toxins. That is food poisoning, ischemic bowel syndrome. That is gut obstruction, some metabolic organ failure. These are some chemically induced nausea. And some gastric stasis, that is there's decreased bowel movements that will can caused by anticholinergic drugs, opioids, ascites, peptic ulcer, gastritis, that is gastritis may be due to stress, drugs, radiotherapy. So these are the things which can cause us gastric stasis that may induce nausea and vomiting. And the stretch or distortion of GI tract, that means stretch means there is stretching of the bowel. Usually we are seeing the stretching of the bowel means usually seen in the constipation. That is constipation, there is the bowel become more enlarged, and sometimes there's an intestinal obstruction may can cause this. These are the things which can cause nausea and vomiting. Next is serosal irritation. Serosal irritation usually seen in liver metastasis, ureteric obstruction, and some irritation of GIT tract. That is usually infections, drugs like NSAIDs. These are the gastric irritants that also result in nausea and vomiting. And raised intracranial pressure, that is usually cerebral edema, intracranial space occupying lesions, intracranial bleeds, in intracranial infections. This will result in a raised intracranial pressure, and that may result in nausea and vomiting. And the movement associated, usually that is vestibular disorders, that is motion sickness. So these disorders also usually we are seeing the symptoms of nausea and vomiting. And next is anxiety induced, that is anxiety, that is anticipatory nausea and vomiting. And some environmental, that is food, smell of some food or some bad smells like some colostomy, ostomy smells, cleanliness, distaste. These are the things which can cause nausea and vomiting. So in our coming slides, we can discuss in detail about the what are the mechanism, how these causes will result in vomiting. So the objectives for the treatment, why we are treating or why we are give appropriate treatment for the nausea and vomiting, because to stop or reduce the frequency of the vomiting and to establish a compliance of the treatment to a patient. That is because if we are providing a good relief for the nausea and vomiting, the patient has a good compliance to the treatment. And to administer oral medications, if the patient has reducing the frequency of the vomiting, they can take oral medicines and also take orals, oral food, and also fluids, solid foods, semi-solid foods. And because of these things, we can improve the quality of life of a patient. So why we are dealing with the principles of management. So first, you think that if any correctable cause is there, so if anything is there, you just correct the cause and any correctable cause. And next thing is non-pharmacological measures and some dietary modifications, and we can use the block the receptors at various sites. That is a mechanism-based drug therapy. And the last thing, that is mainly the pharmacological part of management. So now we are discussing some non-pharmacological measures to treat the nausea and vomiting. So avoid situations which induce nausea and vomiting. So some patients has some smell of some food or some other food materials. So other bad smell from the surroundings. So you have to find out what are the situations which may induce nausea and vomiting, and you have to identify that and you can correct it. And next, calm and reassuring the environment. And you have to give a calm and reassuring environment, because most of the time the patient is vomiting, he is more irritable, more anxiety, there is fear, everything is there. You have to give an assurance, and you have to make a more calm and give a good air circulation in the room. So that will be very important. And give a fresh air and a nurse in the upright position. That usually the feeding position, that is maybe in the most of the time the bedbound patients, there is feeding position is very important, most for the oral intake and also for the rise to feeding. So there is upright or propped up position or reclined position, that is very important for the feeding. Otherwise there is a high chances of nausea, aspiration or regurgitation, vomiting, everything can happen. So you have to tell the caregivers about that, and also our staff. And there is a good oral hygiene, that is also very important, because most of the time the patient become more bedbound, and because of the nausea and vomiting, there is a oral hygiene is not maintained properly. So you have to think about that, and you have to educate the patient and the caregiver about the need of the maintaining good oral hygiene. And there is a control of malodor, that is usually the patient is having colostomy or maybe some fungating foul smelling wound or some decubitus ulcer. This also make induce nausea or vomiting. That also very important. If the patient has a colostomy, you have to teach the caregiver or patient for the good colostomy care. And there is for the foul smelling fungating wound, you have to treat it. That usually we are giving a metrogel injection wash or metronidazole crushed tablet powder dressings, and also then that nebulization with the metrogel injections, that is also we are providing to reduce the foul smell of these fungating wounds. And there is a suitable distractors, that is usually the patient has some other interest or something, you have to tell the patient to engage more with that distractors. That is, otherwise the patient has a continuous symptoms and they are more thinking about the diseases, it is more causing more distress and stress to the patients. So that you have to identify. You as a palliative care physician, this is also very important, and as same as that is medical management. That's why we are more telling in detail about each and every points. So we already discussed there's some dietary modification. So most of the times the patient has not able to take the food as earlier. That is maybe some swallowing difficulty. There is maybe oral thrush is there, and there is some swallowing difficulties, or there is some decreased appetite. So you have to tell that there is, you can take a frequent small mix, there is small quantity in different timings. That is, the patient is able to take in half dosha or one dosha at the morning time, so can try it after 1 hour or 2 hours. That is small frequent meals, and consume food during the daytime. And you can avoid fatty food, sweet, spicy, and carbonated drinks, because it can worsening the nausea and vomiting. And eat food that are easy on the stomach to digest. That is semi-solid consistency or liquid consistency. So to avoid too much fatty foods, and also you have to avoid forceful feeding. That is also very important, because that can result in nausea and vomiting, because most of the time the patient has this decreased appetite, swallowing difficulty. That's why they are not able to take the food as earlier. But because of our love, the caregivers will forcefully giving the foods, that is maybe every minutes or every half an hour or every hourly. So that can cause more distress to the patient. So that is also you have to think that, and you have to give do not give a forceful feeding to our patients. You have to understand their feelings also. So what else? other than this part, there is keep the mouth clean and do oral care after each episode of vomiting. If the patient is not able to brush properly, you have to give a oral care. Usually we are giving oral. If not able to brush the teeth, we will provide, that is, if thrush is there, we can consider oral or injectable antifungals or candid mouth paint. Otherwise, in the home-based settings, we are giving, that is, soda bicarbonate and sodium chloride oral solutions for giving a good oral care. And you advise to wear loose fitting clothes and have a fresh air with a fan or open window, and limits the sounds, sights, and smell that can cause nausea and vomiting, and give a contact information if nausea vomiting is not controlled. And you have to assure that we will with you, and we will give medicine. If you have any persistent symptoms of worsening, you have to contact us. We will give some, we can try some other medicines. You have to give assurance to the patient. That is also very important. So these are some non-pharmacological measures we can consider, or we can try just before the pharmacological management. So next we are coming to the pure pharmacological part of the nausea and vomiting management. Here, usually we are giving antiemetics. That is, you have to, before that, you have to identify what is the cause of vomiting in each person. That is very important. And identify the pathway which triggers the vomiting reflex. We are, in our coming slides, we will discuss in detail what are the different trigger zones and what are the different pathways for activating the vomiting centers. And identify the neurotransmitter receptor involved, and choose a potent antagonist to the receptor identified, and choose the route of administration. It can give an oral or IV or subcutaneous. You have to find out, and you have to titrate the dose, monitor the patients for the symptom relief, and it can be administered regularly. So these are the something you have to keep in your mind before giving an antiemetic. So you are in this is we are coming to a mechanism of action of the vomiting. Here, if someone has vomiting, so something happening in our brain. So we have a vomiting center in our brain, that is in the medulla. We have a vomiting center. So when the vomiting center become activated, the vomiting will happen. So how the vomiting center will activate? So there are four areas. There are main four areas which will send signals to the vomiting center, and that will stimulate the vomiting center, that will result in vomiting. So this is a little bit confusing, so you have to learn carefully, because you have any doubts, you can ask in between. So there are four areas, that is, one is GIT, the next thing is cortex, and the third thing is CTZ. What is CTZ? Anybody knows what is CTZ? CTZ? No. It is a chemoreceptor trigger zone. That is CTZ. It is a chemoreceptor trigger zone. And the fourth thing is vestibular. So there are some reflexes coming from the GIT, that is due to some gastric irritation or something, and that will stimulate the vomiting center, that can be result in vomiting. And there is one area in the brain, that is cortex, that also sends signals to the vomiting center. And also CTZ. CTZ means a chemoreceptor trigger zone. There is a zone of so many receptors. So here there are, in each area there are so many receptors are there. So when these receptors are activated, that will send signals to this vomiting center. Then it can happen to, it will stimulate the vomiting. So here GIT, there are so many receptors. Cortex also, there are so many receptors. CTZ, there is D2, dopamine receptors, serotonin, 5-HT3 receptors, opioid receptors, mu receptors, neurokinin. In vestibular area, there is acetylcholine receptors, histamine, antihistamine receptors, histamine receptors. There are so many receptors are there. When these receptors are activated in the periphery or in this area, it will send a signals to the vomiting center to activate, and this this will happen. This will cause vomiting. So in the coming slides, we will discuss in each area in detail. So you have to think that's 4 areas. That is area prostrema, that is in the CTZ, GIT, cerebral cortex, and vestibular nucleus. So first thing is the GIT, usually gut wall. In the gut wall, what happens means chemotherapy or radiation-induced nausea and vomiting. Usually, while we are giving the chemotherapy or radiation, there is some tissue damage occur in the GIT. This tissue damage can occur in the gut wall. So this tissue damage will induce the release of serotonin from the gut wall. This serotonin will stimulate what? There is something called serotonin receptors in the CTZ, that is chemoreceptor trigger zone. It will stimulate the serotonin receptors, and that receptors will stimulate the vomiting center, and that will result in vomiting. Okay. That is, there is some tissue damage occur while receiving chemotherapy or radiation, or some any other. That is already discussed. There is gastric stasis or any GI that wall distortion or stretching. So anything can happen. There is a release of gut wall, release of serotonin from the gut wall, and that will stimulate the serotonin receptors, and that will stimulate the vomiting center. That will result in vomiting. This is the mechanism. So here the receptors are serotonin. So then we are thinking that if the patient is coming with chemotherapy or radiation induced nausea or vomiting, which drug we can give? Here the main thing is serotonin. So you have to block the serotonin receptors. So we can consider, for blocking the serotonin receptors, we can consider cetrons. Usually the group ondansetron is coming under cetrons. So this is, you have to find out the cause, why this is happening. Then you have to treat according to the cause. Any doubts?
It's clear,
Any
ma'am.
doubts?
It's clear, ma'am.
Okay. Clear. Okay. So next.
No doubts.
Okay.
No doubts in the chat box.
Okay, fine. I think some technical issues, that's why. Okay. So next thing is, usually we are telling that is for the opioids, that is post-operative nausea and vomiting, or in case of surgeries, and also there is an opioid related vomiting. Usually here while we are giving the opioids, it will act on the D2 receptors in the CTZ, that is, and also mu receptors in the CTZ. So while the D2 receptors or CTZ receptors are stimulating, it will send signals to the vomiting center, and that will result in vomiting. So here we are providing dopamine antagonist medicines, that is metoclopramide, because that is if for the post-operative nausea and vomiting means, usually we are giving opioids for the post-operative pain, or intra-operative surgeries. We can give fentanyl or some opioids we are usually using. So in that cases, the opioids are acting on the D2 receptors and also mu receptors in the CTZ, that will send signals to the vomiting center, and that will result in vomiting. In such vomitings, usually we are giving dopamine antagonists, that is metoclopramide. Am I clear?
Participants, please answer now. They have said yes.
No response.
They have said yes in chat box.
Yes. Okay. Okay. So we already discussed the radiation and chemo-induced. Next thing is there is post-operative or some opioid related. Next thing is we already said
One question is there, but
okay.
ma'am, diclofenac is also used in post-op pain management.
Yes, that is, which group of drug is diclofenac?
Rinsum.
That is an NSAID. We are telling that it is for the opioids. NSAIDs usually they are not causing any nausea and vomiting. Opioids can cause nausea and vomiting. That's why.
For what we can give Perinam? Rinzin is asking.
Cannot see the chat box. That's why.
Ma'am, this one, Ringzin is asking.
Yes.
For what we can give Perinam?
Perinam.
Yeah.
Perinam means metoclopramide.
Yes. She's asking indication for metoclopramide.
So it is a D2 antagonist.
Okay.
That's why we are considering metoclopramide for this nausea and vomiting induced by the opioids.
Okay, ma'am. Continue, ma'am.
Continue.
Yeah.
So next we are dealing with vestibular apparatus. So here, while we are discussing about the vestibular apparatus, there is something motion sickness. Usually the some of them have this problem, that is motion sickness. Here, there is a histamine and acetylcholine receptors are induced. So this histamine, while the histamine receptors are induced, it will send signals to the vomiting center, and that will result in vomiting. So in that cases, we are considering antihistamines. So if the patient has a motion sickness, we did not prescribe MSH or some metoclopramide. So here we are giving antihistamines, usually Novamin. So that is the dicyclomine, that is the antihistamine drugs. So that is the medicine of drug of choice for the motion sickness or vestibular apparatus related nausea and vomiting. So next thing is cerebral cortex. This is the third area. Usually there is we have different areas in our brain for each our functions. So because of that, the cerebral cortex has, if the patient has some bad taste, smell, sight, memory, so these will induce the cerebral cortex, and that will send signals to the vomiting center, and that will may result in vomiting. Usually, this is the mechanism for the anticipatory vomiting. We already discussed that what is anticipatory vomiting. So this is the mechanism of it. It is mainly the action is through the cerebral cortex. So here, I already tell there is some anxiety part. Everything was there for this anticipatory vomiting. So here the drug of choice is the benzodiazepines. So to reduce the anxiety part, and that's why we are giving benzodiazepines. This is low dose benzodiazepines are the drug of choice for this anticipatory vomiting. Next thing is some biochemical cause. Biochemical causes means some uremia, hepatic failure condition, ketoacidosis, and hypercalcemic conditions, some toxins. So these will directly stimulate the CTs, that is chemoreceptor trigger zone, and that will send signals to stimulate the vomiting center in the medulla, and that will result in vomiting. So here usually we are giving the drug of choice is haloperidol. So usually we are giving, that is for the uremia, hepatic failure, ketoacidosis, hypercalcemia, and toxins. That is by the stimulation of the CTs, we can give haloperidol. So next thing is raised ICP. Raised intracranial pressure means here there is something, some tumors, usually some space occupying lesions, or some brain metastasis, or some intracranial bleed, or some infections, meningitic like infections. In these cases, there is some edema in the brain. So that will result in the pressure, increase the intracranial pressure. So there is some point or some symptom which is particularly seen in vomiting, that is mainly due to intracranial raised pressure. What is the specific vomiting which is seen in the raised ICP? Anybody can tell?
Characteristics of vomiting seen in raised ICP.
It's a particular type of vomiting. The patient will tell. Anybody?
Nobody has given in chat box.
Okay, ma'am. Okay. Anybody heard of projectile vomiting?
Yes, ma'am.
Projectile. The patient will tell, our caregiver will tell, the patient will start vomiting and it will reach far from the patient.
Yes.
That is away from the patient. That is the projectile vomiting. So this is a typical picture, or it is a clue for our to identify that there is something causing some raised intracranial pressure. So in that cases, usually we are giving some steroids. That is, usually we are giving dexamethasones, and we can give injections or oral steroids, and also we can consider radiotherapy. The main action of the steroid is it will reduce the peritumoral edema. It did not do anything for this tumor or some other lesions or infections or bleed. It will reduce the tumoral edema or the brain edema, and that will result in decreasing the pressure, and then the patient may get symptom relief for that. That is the main thing for the raised intracranial tension. So this is the nutshell. That is, we have 4 areas, that is gut wall, area prostrema, cerebral cortex, and vestibular nuclei. And there are some different receptors also seen in each area. And these things are, there is some, what are the things which can induce these each receptors, and that will send signals to the vomiting centers. And that will again result in vomiting. So this is a nutshell of our last previous few slides. So here we just classify the receptors and the appropriate drugs for each receptors. So for acetylcholine, usually we are giving drugs, that is hyoscine or dicyclomine. Antihistamines, that is promethazine, diphenhydramine, cyclizine. For the dopamine, that is dopamine antagonist, usually we can give as a metoclopramide, domperidone. That is serotonin, that is cetrons, that is usually for blocking the serotonin, we can give cetrons, that is ondansetron. For neuroleptics, that is usually in the CTZ, that is chlorpromazine and haloperidol. We already discussed that drug of choice for some CT is a triggering zones, like some uremic condition, a biochemical causes. So here we can give a haloperidol. And some substance P, that is NK1. For blocking the substance P, we can give aprepitant, rolapitant. So these are the some drugs. So most commonly we are using, that is metoclopramide, cetrons, haloperidol, and some antihistamines, and also the as acetylcholine receptor blockade. These are the medicines we are commonly using here. So for the route of antiemetics, so usually as per patient's condition and preference, the oral route is usually the best and the easiest way. But if the vomiting is severe, the patient is not able to swallow it, we can consider IV, subcutaneous, or continuous subcutaneous or IV infusions. And also we can provide as a suppository, sublingual, or transdermal patches also. So, nausea and vomiting management guidelines in palliative care means there is a document the most likely the cause for each vomiting, and treat potentially reversible causes and exacerbating factors. You have to find out any reversible cause is there or not. If something is there, you have to find it and reverse it. That is, if some drugs may cause this vomiting, you have to give appropriate medicine for that antiemetic, or you can withdraw that drugs. And if the constipation will result in nausea and vomiting, you have to treat the constipation. If some patients, because of the severe pain, the patient may can nausea and vomiting, you have to treat the pain appropriately. If the infection, that is meningitis, so you have to treat the meningitis part. And the cough, so you have to find out any reversible cause or exacerbating factor is there, you have to find out and treat that. And review the dose every after 24 hours of starting. So you have to think that if patient has any symptom relief with our current regimen. If nausea and vomiting is persist after 24 to 48 hours, review the cause. If our cause is right wrong. If something is wrong, that's why maybe the patient did not get any benefit after 24 to 48. You have to review the causes once more. And remember, 1/3 of the patients will need more than one antiemetic. That is also because sometimes the patients has more than one mechanism for each vomiting. So that times may need more than one antiemetic. If on parenteral, consider converting to oral after 72 hours of good control and to on oral regimen. If the patient is not able to take oral, we just started on a parenteral route. So after for 72 hours of good symptom relief, you can convert it to, or you can convert it to an oral regimen. Because most of the time the patients are preferring oral rather than IV or subcutaneous. So that is the most important. So rule out any other causes. We already tell that any causes for severe pain, infection, cough, hypercalcemia, anxiety part is there, constipation. So you have to find out any other causes is there. You have to treat that cause appropriately. And you have to always prescribe the most appropriate antiemetic for based on their receptors. And write the stat and regular and SOS doses. You have to, if sometimes the patient need only stat doses, sometimes the patient need regular dose, that is maybe 8th hourly or 12th hourly or maybe 4th hourly. So maybe continuous infusion. And also some patients also need some rescue doses also through the breakthrough pain, breakthrough vomiting. So that is also very important. And the choose parenteral route. If continuous nausea and vomiting is there, you can choose parenteral route. So single antiemetic may not be adequate. For example, that is if the patient has a raised intracranial pressure and the patient has a features of uremia, you can give, there's a combination of medicine. That is, we already tell that, for the raised ICP, we can consider steroids, that is dexamethasone. For the biochemical use, that is like uremia or some failures, encephalopathy. So that cases we can consider haloperidol. So if the patient is presenting with both raised ICP and uremia, we can give a combination of steroid and also haloperidol. This is a some patients may need more than one antiemetic. So this is little bit more about metoclopramide, because this is the one medicine we are commonly used in our palliative care, mainly because it is mainly for the opioid induced vomitings. So here there is 3 mechanisms that is for the metoclopramide. That is, one thing is it is a D2 antagonist, and it can also as a 5-HT3 antagonism, and it is a cholinomimetic. Cholinomimetic means it can act as a prokinetic agent. What is a prokinetic agent? Anybody knows what is prokinetic? It can induce peristalsis and push the gut forward, and it will reduce the gastric stasis. That is a prokinetic action. Because if some patients presenting with some partial bowel obstruction, so in that time, the patient has a nausea and vomiting with the partial bowel obstruction. It has a dual action. It is appropriate for this vomiting, and also it can also act as a prokinetic agent. It will induce the peristalsis and push the gut forward, and the protrude, that is push out the bowel contents out, that is by inducing the gastric movement. So this is a prokinetic action also there. Usually the dose is 30 to 120 milligram per day. We are giving as a 10 milligram, we have 10 milligram tablet and also injection also as a 10 milligram. We can give as a TDS, that is 8th hourly. And if the patient has a severe vomiting, we can consider for the 4th hourly also. And also we can consider it as a continuous infusion. If the patient has a persistent severe obstruction due to the bowel, we can consider that is a continuous infusion also. That is a IV infusion or subcutaneous infusion. The normal duration of action is 6 to 8 hours. That is about the metoclopramide. Next thing is little bit about haloperidol. Haloperidol, it is a D2 blocker. It is also an antipsychotic, and it mainly acts on the CT receptors. So it is mainly it can used for the morphine-induced vomiting, which is not responding to the metoclopramide. If we already said the opioid-induced vomiting, we can give metoclopramide. Sometimes, if the metoclopramide is not working, we can consider haloperidol. The dose is 1.5 to 5 milligram per day. The tablet is available as a 1.5 milligram tablet. So for the vomiting, we can consider it as a 0.75 milligram to 1 milligram as an HS, and also we can give as an rescue doses also. It is also can give us an oral, IV, and also subcutaneous. All three forms are available. So I already tell there is some anxiety-induced vomiting is there. That is some anticipatory vomiting. So in that cases, we will consider benzodiazepines. Usually we are giving lorazepam or clonazepam. Lorazepam is 0.5 to 1 milligram as an HS dose, and clonazepam it is 0.25 to 0.5 milligram HS dose. This is mainly for the anxiety-induced vomiting. So in nutshell, there is, I just tell the what are the cause, what is the choice of medicine. That is for drug induced, that is mainly the opioid induced and some uremic causes that we can consider haloperidol. For radiotherapy or chemotherapy induced, we can consider as an cetrons, that is ondansetron. Usually, little bit high dose for the radiotherapy and chemotherapy induced vomiting, that is 8 mg tablet as a stat, and we can consider it as a 4 mg TDS. Same as that of chemotherapy. And also we can consider short duration steroids also, because there is some edema maybe there due to the chemo and radiotherapy. That time we can consider dexamethasone also. And that is some metabolic, that is uremic condition, like that time we can consider haloperidol. And for the raised ICP, we can give dexamethasone. For delayed gastric emptying, that is as a prokinetic agent, we can give metoclopramide. And for the gastric irritation, usually there is some, we can consider proton pump inhibitors, and you have to find out what is the gastric irritants, and you have to stop the irritants. Usually there's NSAIDs and some other toxic materials. So you have to find out some NSAIDs is there, you have to stop it. And we can provide proton pump inhibitors to reduce the irritations. So this is something about opioid-induced vomiting. So it is a different mechanism. Is we already told that there is a different mechanism, that is CTZ, and it increases the vestibular activity, stasis, constipation. So the drug of choice is metoclopramide or haloperidol. So it prevents with an initial antiemetics, usually 10 milligram TDS and SOS. So after starting these medicines, you have to review the patient for the symptoms after 24 hours. That is very important. If record, adjust the dosage or use combinations. That is 1/3 of the patients need combination medicines. So you have to review the patient after 24 hours of starting antiemetic regimen, and revert back to oral from parenteral if symptoms subside. Thank you. These are the things. I think it is little bit confusing. That is that management part with the mechanism and the trigger zones, 4 different zones. So after this class, you have to go through the slides once more, and you have to study well about each zone and the receptors, because there is some questions maybe there in our exam point of view. What are the medicines appropriate for each triggering zone or receptors? So apart from the examination point of view, the management of our palliative care patients is also very important. I already told just before the class. Before this class, you just give medicines that is anti-emetic, that is means emisate for all patients. So after this class, you have to think that what is the cause of vomiting in each patient. Then only you can prescribe what is the anti-emetic.
Thank you very much, Dr. Susan. Very nice, interesting, and very simplified, easy to understand. Thank you so much. You have taken very nicely. Participants, do you have any doubt on this topic? Ma'am, how effective?
Yeah.
How effective is Perinam by IM route?
I am not sure about the IM route for the metoclopramide. We are usually giving as a subcutaneous, oral, and IV.
We usually don't give IM injection in palliative care. We go
it's
for
a painful thing.
Yeah, it's very painful. So we go for IV or subcute or other oral route, or like that's all. Okay, we never go for IM.
Yes.
So it's painful. Any other doubt?
Ma'am, with the increased urea, there is nausea, ma'am. So can we give MSIT, nausea and vomiting, if it's increased urea and kidney failure patient? Can we give MSIT tablet, ma'am?
That I already tell that there is some biochemical conditions like uremia, that is kidney failure patients. Usually we can give, but the appropriate medicine is haloperidol.
Thank
Yes.
you.
Can we give a Perinam IV? Yes, we can give. Any other doubt? Itself 40 to 70% of the patients, palliative care patients, come across nausea, vomiting, which is challenging for the caregivers. So please ask your doubt and take care of your patients. Or you can share your experience before going for the case discussion. If you have managed successfully any case, you can share what you have done differently. Okay, if no questions, shall we go for case presentation?
Yeah, I hope there is no more questions. So I'm inviting Sister Daisy to present the case. I will be sharing the screen. Sister Daisy? Sister?
Yes, I am here.
Okay.
I cannot see you because I am in a poor network connection area. So I will be presenting. Can you hear me?
Yeah, we are able to hear you.
Okay.
You try, sister. You try. If not possible, then we'll ask someone to do. You try.
Once it is gone, to get back, it is very difficult. That is why.
Okay, it's okay. It's okay. You try.
There is a technical difficulty from my side. I'm not able to share the screen. Give me a single minute. By the time, if there is any more doubts, you please ask. Okay, is it visible?
It's
Yes.
visible.
Yes.
Okay. Sister Daisy, please present.
Okay. A patient, age 51 years, female patient. The diagnosis is differentiated sigmoid colon after adenocarcinoma. The presenting complaints: nausea and vomiting with blood, melena, constipation, if taking laxative, diarrhea, generalized weakness. History of illness. A 51-year-old female patient with a known diagnosis of differentiated sigmoid colon adenocarcinoma, currently receiving palliative care. Progressive decline over the health over the past few weeks. Multiple episodes of nausea and vomiting with the presence of blood. Noted fresh blood in stool worsening over time. Associated along with these symptoms
I think she's stuck.
Hello?
Sister Daisy, can you hear me?
Yes, I can hear.
So please continue.
It was blocked. So, shall I continue?
Sure.
Yeah, continue.
Multiple episode of nausea and vomiting with the presence of blood. Noted fresh blood in stool worsening over time. Associated along with these symptoms, she experiences generalized weakness, fatigue, loss of appetite, and weight loss. The patient had multiple prior cycles of chemotherapy, but due to disease progression, the focus has shifted to symptom relief and comfort measures. Clinical considerations: suspected gastrointestinal bleeding from tumor erosion or mucosal damage, anemia likely secondary to chronic blood loss, weakness potentially due to anemia and poor intake. Next, please. Examination. The clinical examination: general appearance, pale, swelling over the face, weak, disappointed, anxious, dehydrated. Vital signs: BP is 98 by 62 mm per Hg, pulse 104 beat per minute, tachycardia, temperature 98.6 Fahrenheit, respiratory rate 30 per minute, SpO2 96%. Abdominal examination: abdomen soft, non-distended, mild lower abdominal tenderness, especially in left iliac region. No palpable masses. Bowel sounds hypoactive. No signs of peritonitis or ascites. Renal examination positive for frank blood. No obvious masses felt due to tenderness. Cardiovascular, normal heart sounds, tachycardia noted. Respiratory, clear breath sounds bilaterally. Neurological, alert, oriented, but reports weakness. Episcopy, evidence of active bleeding from ulcerated tumor site in sigmoid, and biopsy. Next, please. Treatment and significant investigation. Laboratory findings: CBC, hemoglobin 3.9 gram percentage, WBC, mild leukocytosis, platelets normal, electrolytes and renal function, mild hyponatremia and elevated urea, liver function test, mild hypoalbuminemia, CT abdomen and pelvis, mass in the sigmoid colon with mural thickening. No evidence of perforation. Regional lymphoadenopathy present. Endoscopy, evidence of active bleeding from ulcerated tumor site in sigmoid colon. Next, please. Psychosocial aspects. Emotional and psychological. Anxiety and fear related to disease progression and prognosis. Depression symptoms, low mood, hopelessness, social concerns, unable to fulfill family responsibilities, financial burden due to medical expenses and loss of income, social withdrawal, needed for spiritual support or counseling, especially if religious. Next, please. Medications. Medication is focused on symptom relief, stabilization, and comfort for patients in palliative measures. Antiemetics and proton pump inhibitors for nausea and vomiting, ondansetron 4 mg IV 8 hourly, injection pantoprazole 40 mg IV 12 hourly, haloperidol 0.5 mg OD. Analgesia management tablet, paracetamol 1 gram SOS for mild to moderate pain, tablet tramadol according to the severity of pain. 4 unit of blood transfusion for anemia has done. IV fluid for dehydration management, injection tranexamic acid 500 mg IV 8 hourly for GI bleeding. Syrup Dulflax 10 ml HS. Main concerns: acute gastrointestinal bleeding, nausea and vomiting, severe anemia and generalized weakness, pain control, symptom management, recurrent hematemesis and melena, psychosocial and emotional distress. Summary: a 51-year-old female with a known diagnosis of differentiated sigmoid colon adenocarcinoma is currently under palliative care due to the advanced stage of her disease. Presenting complaints, nausea and hematemesis and blood in stool, generalized weakness. These symptoms are likely indicative of gastro-intestinal bleeding, possibly due to tumor progression or related to complications. Findings: evidence of active GI bleeding, anemia, weight loss, and psychosocial distress and functional decline. Investigation: anemia on CBC. Abnormal imaging showing tumor mass. Suspected metastasis and mucosal ulceration. The clinical focus is now on symptom control, quality of life improvement, and supportive care, while considering the patient's overall prognosis and palliative goals. Discussion points. How can we effectively manage GI bleeding in advanced colon cancer patients with curative treatment is no longer an option? Second, what are the best strategies for managing refractory nausea and vomiting in palliative care? When should palliative care be introduced in patients with GI cancers?
We'll go back to the question. Thank you, Sister Daisy. Very nicely written. You have presented very well. And the technology also helped. Okay. So now we'll go for one by one. Actually, in this session, we have not discussed about management of GI bleed. Dr. Susan, would you like to take that topic?
I think that is mainly for the GI bleed. Usually, GI stomach or GI esophagus, the symptoms are more commonly seen, that is upper GI bleed. So, how we can effectively manage means the 100% effective management is not possible usually in advanced cancer patients. So, we can consider that is agents like tranexamic acid or etams. Usually, the patients are presenting with a coffee-colored vomiting or fresh bleeding, that is hematemesis or hemoptysis. So that time we can consider that is tranexamic acid or ethamsulate, and also we can provide that is rice soup, that is for the decompression of the stomach. It's little bit effective for this GI bleeding. And these are the main things. And sometimes the steroids may worsening this GI bleed. So that time you have to cautious in for the use of steroids for the upper GI bleed. And anything, ma'am, you have to add?
Thank you, Dr. Susan. I want to ask the participants. You have listened to the case study. Can you list the triggers the patient had for nausea, vomiting? Participants, you can list the triggers so that we can discuss the management. What are the triggers the patient has for vomiting? Somebody? Swati? Or Deepa?
Nobody listen.
Pain, very good. Pain. Yes. Anything else? Anything else? Even madam's class also, madam very nicely explained. What are the triggers? The first CT set itself, what is the trigger? The serotonin receptor. How the serotonin is released from intestine. Sister Deepa, please unmute and answer, na, please. Then only we'll be happy. Sigmoid colon. Okay. Mass present. Yes. There was a mass sitting on the sigmoid colon. Obstruction. Okay. Anything else? That causes pain and tissue damage. Yes. Tissue damage stimulate the release of serotonin. Very good. The first trigger is pain. Second one is there is a tissue damage which stimulates the serotonin. Then any other electrolytes? Something was raised in the history. Sister Pushpa, constipation. Okay, very good. Yes, constipation is the major cause of nausea, vomiting. Anything else? In the electrolytes, something was raised. Anxiety. Yes, yes, very good. Yes, she was having anxiety. One more triggering point. Fear, yes. Fear, okay. Anything else? Any electrolyte? Intake of haloperidol. Okay, they have given haloperidol for vomiting. Environment. Okay, anything else? One more. Something was raised. Some electrolyte was raised. So, okay. So, urea was elevated. Very good. Yes, somebody has come to the answer. Okay. So, now you know what are the triggering points. So, this patient is having a all except that vestibular reason, all the other cause the patient was having. So, and also this patient is having a refractory nausea and vomiting. So, how can we manage? Can you please put it in chat box or you can answer. Unmute and answer. How can we manage this patient? Okay, before going to the answer, what is refractory nausea? Madam very clearly explained in the class. Mr. Vignesh, are you listening?
Ma'am, it seems like participants are not as active as the previous sessions, isn't it, ma'am?
Yeah. Diana, unmanageable. Okay. Sister Shanti, what happened? Projectile vomiting. No, refractory nausea means. Madam said, na, refractory nausea, types of vomiting, unmanageable with
nausea, ma'am. Severe nausea.
okay. Even
No,
with the adequate,
nausea that returns after giving MSET, anti-MSET.
yes, even with the adequate amount of antiemetics, we are unable to control the nausea. Very good, very good. So many of them have answered correctly. So can you answer this question for this? Sorry, answer. Best strategy for managing refractory nausea and vomiting in palliative care. Okay, ma'am, Dr. Susan, over to you.
Somebody says we can first treat the reversible cause such as constipation. Yes. So everybody tell that there is so many triggering factors are there. That's why in the treatment part, I think there's only ondansetron and haloperidol is there. So you have to think about the other medicines also, because here there is some constipation, there is a partial bowel obstruction features also there. So you can consider that is metoclopramide. That is, it can also has an action of prokinetic. So we can consider metoclopramide for here. And also you have to think about some short course of steroid also. There is a combination therapy. Usually for the refractive nausea and vomiting, you have to think more causes. That is rather than one cause, there is a more causes. So you have to think more antiemetics. That is, a combination therapy is more effective than a single antiemetic therapy for the refractive vomiting. So here we can consider this metoclopramide and also short duration of steroids. That is dexamethasone also may help the patient to relieve the symptoms. Anything?
Anything antiemetic upright position, yes. Pharmacological,
And
non-pharmacological.
non-pharmacological measures are also very important.
Are you all happy with that answer, participants? Okay, we'll go to the next question. Next question is, when should palliative care to be introduced in patients with the GI cancers? Okay, you all may be remembering the first class.
First class, yes, ma'am.
So now you should answer. Deepa is not at all talking. At the time, what? At the time of diagnosis.
At the time of diagnosis.
Very good, very good. So many of them have written at the time of diagnosis. So can we have 16 minutes time. So in the ma'am's class, yes, very good, very good. All of you have written palliative care to be started at the time of diagnosis itself. So for this patient also, at the time of diagnosis itself, we should have introduced the palliative care. Very good, very good. Everybody has answered at the time of diagnosis. So I am going to, since we have 12 more minutes, I'm just going to give you the a glimpse of this class, what we had. Madam explained that 40 to 70% of the palliative care patient experienced with the nausea, vomiting. The class, why we have to learn this classes. We have to know the cause for the vomiting to manage decide about the antiemetics. So that is why this class is being taken. And we all know that Emisset is the wonder drug, but it is not only the drug. There are many drugs are there, and we have to go for the targeted treatment. And so why we have to go for managing this patient nausea vomiting is, it affects the patient's daily routine and affects the patient's quality of life. And many patients, because they are not able to control the vomiting, they become non-compliant, and inadequate symptom control, which affects the absorption of the drug which is given, and also patients further worsen the distress. So that is the reason we these are all affected by the nausea and vomiting. And what do you mean by emesis? It is a defense mechanism. So madam said there are 4 phases. Nausea. What is the second phase? Anybody put it in chat box? First one is nausea. Second one is immediately nausea, vomiting. Second one. Third one is vomiting. Retching. Very good. Retching. Third one is vomiting. And fourth one is regurgitation. If you want to say one word, nausea, what do you say? Nausea, one word, what do you say? Nausea in one word, what do you say? It is the sensation. And very good, Sister Jolly, very good, sister. And if you think retching, what do you think in one word?
Spasmodic, ma'am.
Very good, excellent. Vomiting means in one word?
Movement against global glossitis, ma'am.
Okay. Forceful expulsion. Okay, very good. Regurgitation means very good, Sister Jolly. You are very attentive in the class. Then regurgitation means?
Contraction of the abdomen.
Very good. It is bringing back the stomach content. Very good. So what are the types of vomiting, madam taught? Please unmute and answer now. What are the types of vomiting we have learned in this class session? We have 10 more minutes.
Acute breakthrough.
Acute delay.
Chemically induced vomiting.
Breakthrough.
Yes.
Gastric.
Acute delayed breakthrough, refractory and anticipatory.
Very good. So acute means?
Acute means few minutes.
Yes.
Few minutes to 1 hour.
And it resolves within 24 hours.
24 hours.
Very good. Delayed means?
After 24 hours, worsen for 48 to 72 hours,
6 to
last
7 days.
for 6 to 7 days.
Very good. Excellent. You have listened to the class very nicely. Breakthrough means?
Occur in spite of antiemetic treatment.
Then what is the difference between breakthrough and refractory?
Refractory with unmanageable with the current antiemetic regime.
Yes, very good, very good. Deepa, I thought you were not attentive.
No, I am writing the notes and all. Then it will take time
very
to.
good. Very good, Deepa. Okay. Anticipatory means?
Anticipatory condition
response prior to chemotherapy.
Okay. So what do we give for anticipatory vomiting? What do we give for anticipatory vomiting? This is because of
Haloperidol, ma'am.
anticipatory. Like anticipatory means like I am getting tension for thinking of tomorrow's chemo. Very good. It's for anxiety. Okay, what do we give?
Haloperidol.
Yes, somebody has written benzodiazepines. Very good. So anti-anxiety we have to give. Very good. Okay. So for chemical cause, what is the drug of choice? Chemical cause. Very good. Somebody has written haloperidol. Very good. And what are the four areas we have to remember when we think of vomiting, nausea vomiting? 4 areas. Madam showed now 4 boxes. Vomiting center in the center, 4 areas.
Yes.
What are the 4 areas?
GI, cortex,
First one,
CT set, vestibular.
okay, Sister Pauline, super. Very good. So what is the drug of choice for CTZ? Serotonin.
Serotonin, yeah. Serotonin.
Cetron. Okay, so you remember, madam very nicely she put it in the slide. serotonin, ondansetron,
Ondansetron.
on. Okay.
Ondansetron.
Yes. So post-op surgery and opioids.
Opioids.
Metoclopramide.
Very good, because it is a dopamine antagonist. Very good. Okay, vestibular. In case when we are traveling, if we have nausea, vomiting, what?
Antihistamine.
Histamine.
Avomine.
Okay.
Antihistamine.
Yes.
Anti-
Very good. Okay. Okay.
Antihistamine.
Okay. In case of increased ICP.
English ICP Dexona.
Dexamethasone.
Very good. Okay.
Dexam-
Okay. So, okay. And in case of morphine-induced vomiting.
Morphine, opioids.
Opioids. For opioids, what do we give?
Haloperidol.
Very good. Excellent. So what are the route we choose for antiemetics?
IV or subcutaneous.
suppositories,
First, we
sublingual,
try through
Oral
oral
IV.
route. Always
oral and
Oral
yes,
IV.
IV,
And
Oral IV
subcutaneous,
sublingual.
suppositories, sublingual, transdermal.
okay. Very good. So what is the three action of metoclopramide?
Lead to
Antagonistic.
prokinetic agent.
Very good.
Lead to
Five,
antagonist.
Lead to
5
antagonistic. Very good.
Polinometric.
Colonimetric.
5H3 antagonistic. Very good. Very good. Okay. Ma'am, are you happy? Student, all the participants have answered satisfactorily.
I am so happy, ma'am.
Okay. Okay, Arya. So many answers are there.
Okay, it is a very sashable completion of a session, ma'am. Thank you so much, Dr. Susan, for the wonderful session you had. Actually, while I was approaching her for the session, I was really I was fearful because I know she has a small kid, and I was almost sure that she will not agree for this timing. But she showed the mercy to handle the session in this timing itself. Thank you so much, ma'am. And thank you,
That is
Dr.
the
Lata.
speciality of being in Pallium Media under palliative care.
Yes, ma'am. She's so simple and she's a kind personality. I'm seeing her on all days. She's a kind personality. Thank you, Lata ma'am, for the Q&A session, the question and answer session. While the question and answer session was progressing, I was sitting here watching it. The expressions of Dr. Susan ma'am. She was smiling throughout the session. She was smiling with satisfaction. It was so sweet to see. Thank you all the participants for the very. I was really startled to see the answers. You are so attentive, so attentive. We are all happy to see that. Thank you all for the active involvement. We will see in the next session. Till then, bye. I am thanking once again the faculty as well as the facilitator. And it was a wonderful case presentation, Sister Daisy. It was really nice. Keep it up. Thank you. We'll see in the next session.
Okay, bye. Thank you.
all.
Thank you all.
Thank you, ma'am. Thank you.
Thank you. Thank you.